Hello everyone, this is Chadi Alraies from New York AVS. I'm really privileged to be with Dr. Bianchi, who's coming from Italy, but he's practicing in California, who did a phenomenal talk at the conference and symposium related to DCB. Christian, thanks for being with us.
My pleasure.
Okay, so we know this FemPop space is the most commonly used bed for intervention. DCB has been there in the market for a while. There was some dilemma in the past, and now it's cleared up. So tell us what's the current state.
Absolutely. So the space is dominated by paclitaxel base DCBs, and I think all the trials have been positive when they're compared to balloon angioplasty alone. Then the safety concern came. We spent a lot of energy and time and money, and I think the FDA was able to release that letter on July 11th last year saying there's really no concerns anymore. So I think we have that behind us. We had even evidence that different doses with different excipients proven to be efficacious. So I think we have solid, robust data, randomized controlled data between the two DCB dose and excipients that proves that you achieve adequate patency in the femoral segment compared to PTA alone. What I think the future is holding is limus base, and limus certainly has improved significantly the outcomes in coronary circulation, but as we know, the SFA is not the coronary bed. So limus is coming. There's a lot of portfolio in different limus base coated balloons that technology now allows them to be more reliably released. And we are waiting for that head-to-head comparison between limus versus paclitaxel one-to-one.
Absolutely. So question to you about, if it is like mild, not a significant disease but not CTO, is there a difference performance of the DCB in different lesions, CTO intervention versus non-CTO?
Excellent, yeah. And again, I think some of the trials include stenosis or occlusions. Obviously, everything that is to get to the FDA, US market are going to be not real-world lesions, but we do have a robust real-world registries that supports the notion of longer lesions and CTOs. So I would say that the space is lesions that are short, long, CTO or stenosis, they all benefit from compared to. So I think DCBs have largely replaced PTA in this setting, yes.
Is it fair to ask a question, DCB versus stenting?
I think it is fair. I think it's provocative. I think most of us have transitioned to try to not have stents behind, and I would venture that the best of both worlds with bioresorbable technology applied to the femoral segment as well as the tibial segment may be the future of what we do. Drug release that is reabsorbable. I'm not quite sure that is going to be the case, and I'm not quite sure how many decades it's going to take us, but I think we probably are going to go that way. But yeah, absolutely. There is not a head-to-head comparison at this point. I think that the stent literature continues to be a silo, and they're comparing limus versus paclitaxel base. Again, paclitaxel has dominated the femoral segment and has even work off-label in the below-knee segment as well, versus paclitaxel-based balloons have failed miserably in the BTK segment, but maintain domain in the femoral segment. Yeah,
that's great. Okay,
sure.
Well, Dr. Bianchi, really great overview of the DCB used in the FemPop. Great overview of the balloons, and as well as looking for your presentation tomorrow about the below the knee as well. Stay tuned for more interviews. This is Chadi Alraies coming to you from New York AVS. This is New York 2024. Dr. Bianchi, thank you again.
Oh, it's a pleasure.